Welcome to this explainer. Today, we're diving straight into a massive medical mystery that every clinician and motivated patient really needs to see clearly. We are tracking down a master of disguise in the neurological world, a condition that visually mimics one of the most famous movement disorders out there, but actually hides a much darker, much faster-moving reality underneath. Today, we're unmasking multiple system atrophy, or MSA. Okay, picture this case because it brilliantly illustrates what we're looking for. You have a 58-year-old man who comes in referred with a standard diagnosis of Parkinson's disease. And on the surface, the visual clues seem to fit perfectly. He's got that classic slowness, the rigidity, but look a little closer at the rest of the picture. He's falling a lot, and we're talking within the very first year. Plus, he's experiencing severe postural hypotension, meaning his blood pressure just plummets dangerously the second he stands up. Add to that early erectile dysfunction and urinary incontinence. Right away, your eyes should be telling you this is not your typical Parkinson's disease.
And that brings us to the core mystery of this whole case. Despite the Parkinson's label, this patient has a genuinely terrible response to levodopa. As you know, that's the gold standard dopamine replacement therapy that usually works absolute wonders for true Parkinson's patients. So, why is it failing him so miserably? Unlocking the answer to that question literally changes everything about how we view his condition.
Let's move into Chapter 1, the culprit revealed, to unmask exactly what's going on here.
So, the crucial takeaway here is that we aren't looking at standard Parkinson's, we are looking at multiple system atrophy. Now, medically speaking, this is a rapidly progressive neurodegenerative synucleinopathy. I know it's a mouthful, but visually it just means an abnormal protein, alpha-synuclein, is clumping up and destroying supportive cells deep inside the brain. Think of this as a Parkinson plus condition. Yes, you see the Parkinsonism, but plus severe autonomic failure and cerebellar dysfunction. It's a total imposter because the neural degeneration is way more widespread than just the dopaminergic neurons. And that perfectly explains why simply replacing dopamine wasn't working.
What's wild is that this culprit actually splits into two very distinct visual disguises. On one hand, we have the MSAP phenotype. This one looks heavily Parkinsonian, so you're seeing rigid, stiff movements, and you get that poor levodopa response we just talked about. This specific form pops up way more in Europe and North America. But then, contrast that with MSAC, the cerebellar variant. Visually, this patient looks completely different. They're uncoordinated, they show ataxia, they have slurred speech, which is dysarthria, and severe gait imbalance. And we see this variant much more commonly in Asia.
Let's actually map this out visually. We can directly link the affected anatomical systems in the brain to the physical symptoms you see right in front of you. When the basal ganglia takes a hit, you visually see the Parkinsonism. When the cerebellum is damaged, you see the wobbly ataxia. When the autonomic nervous system is involved, that triggers the invisible but severe orthostatic hypotension and urinary dysfunction. And finally, when the corticospinal tracts are affected, you'll physically spot pyramidal signs, like hyperreflexia, where the reflexes are just overly jumpy. It is a complete systemic breakdown, which is why looking at the whole visual picture is so vital. Now that we know what's happening inside, let's jump to Chapter 2, spotting the red flags in the clinic. To catch this imposter early, you really need a systematic four-step visual framework. Step 1, always challenge the diagnosis. Are you seeing early falls, rapid progression, or symmetrical symptoms that are practically screaming this isn't normal Parkinson's? Step 2, aggressively hunt for autonomic failure. Ask them directly about fainting or sweating issues. Step 3, check for those plus signs, things like cerebellar ataxia or slurred speech. And lastly, Step 4, systematically rule out other mimics like progressive supranuclear palsy or Lewy body dementia.
Listen, if you only take away one single clinical clue from this explainer today, make it this one. You must watch for disproportionate autonomic failure. We're talking about severe, early cardiovascular issues, like literally blacking out when they stand up. That's the orthostatic hypotension. Combine that with early erectile dysfunction, urinary urgency or attention, and severe constipation. When a patient looks super rigid, but their autonomic system is collapsing this early and this dramatically, your alarm bells should be ringing loud and clear.
And here's a stark, incredible visual clue you might actually catch on an MRI. This is famously known as the hot cross bun sign. Just look at that distinct cross shape lighting up right there in the pons. It paints a perfect visual picture of severe pontocerebellar degeneration. Now, a quick caveat. It's not present in every single case, right? But man, when you do see that cross shape light up on a scan, it is a massive flashing arrow pointing straight towards MSA. Let's pause for a second, though, because we need to ask a really critical question.
What happens if this patient, who looks like they just have Parkinson's, suddenly starts making a harsh, high-pitched breathing sound during their sleep, known as inspiratory stridor, along with severe sleep apnea?
Well, that changes absolutely everything. This is a lethal red flag. Stridor, breathing problems at night, and recurrent aspiration or swallowing issues are incredibly dangerous. You can't wait and see on this. It demands an urgent ENT or sleep assessment right away to get the patient on a CPAP machine, a BiPAP, or in some cases, even perform a tracheostomy. Ignoring this specific symptom can directly lead to sudden death. It's that serious.
Moving right along to Chapter 3, Managing the Uncurable.
Because the neurodegeneration is so widespread, we know dopamine replacement mostly fails. So management has to shift heavily toward treating the symptoms, using a real multidisciplinary approach. Sure, a levodopa trial is usually done, but expect limited success. The actual heavy lifting here is managing that severe orthostatic hypotension. We use non-pharmacological tricks like compression stockings or medications like midodrine and fludrocortisone. We also have to manage urinary dysfunction carefully, maybe with antimuscarinics or catheters, and aggressively tackle dysphagia or swallowing problems through precise swallow assessments and tweaking the texture of their diet so they don't aspirate.
But you have to be so incredibly careful not to fall into a very common, very dangerous trap here. Treating this is a huge balancing act. See, a lot of MSA patients suffer from supine hypertension, meaning their blood pressure spikes way too high when they lie down. But as we just discussed, they also have orthostatic hypotension, where it plummets when they stand up. If you overtreat the high blood pressure when they're lying flat, you can disastrously worsen their low blood pressure the second they stand up. And that leads to them blacking out and taking a severe fall.
Now, the really grim reality of unmasking this imposter is the prognosis. Unlike idiopathic Parkinson's, where patients can often live for many decades, MSA moves fast. Typical survival is merely 6 to 10 years after diagnosis, and this is exactly why recognizing those visual clues early and shifting your management priorities is just absolutely critical for the patient's quality of life.
The sad truth here is that the disease itself usually isn't the direct cause of the end. Most patients actually succumb to the complications of that autonomic and bulbar failure we mapped out earlier. Common causes of death include aspiration pneumonia from poor swallowing, severe respiratory complications, or that sudden nocturnal death linked to the inspiratory stridor we warned about. Spotting those specific red flags visually and managing the swallowing and breathing is literally your best tool for extending their life and keeping them comfortable.
Let's lock all this in. Chapter 4, the 10-second survival summary. To help cement this in your mind forever, let's use a super simple visual memory system. MSA stands for multiple system atrophy, right? But you can also just remember it as many systems affected. The M stands for movement disorder, that's your Parkinsonism. The S is for syncope, representing that massive autonomic failure and fainting. And the A is for ataxia, the wobbly cerebellar dysfunction. If you have a patient who looks like Parkinson's, but they're visually showing you the S and the A, boom, you found the imposter.
So, I want to leave you with this provocative thought. The next time you see a rigid patient taking a sudden, early fall in the clinic or complaining about a severe fainting spell the second they get out of bed, ask yourself, are you just seeing a common disguise, or are you finally ready to catch the deadly imposter? Keep your eyes peeled for these crucial red flags. Always remember, many systems affected, and let's make sure these patients get the precise, multidisciplinary care they actually need. Thanks for joining me on this explainer. Keep learning and keep looking closer.